Hello.
Hello, sir.
Okay, how are you?
I'm good, sir. Happy doing it.
Okay, so today we have the cardiovascular section from the critical care.
Okay.
Okay,
Okay. Okay.
so this is your scenario. Kindly review it and then we will start.
Okay. Yes, sir.
Okay, so what are the benefits and risks of this patient undergoing the operation?
Uh, the benefits. One second, sir. The benefits is since the patient is 34 weeks pregnant and is going in for a sepsis if the surgery is not done. So we can remove the sepsis component at the right time. We can also prevent preterm labor and also fetal loss. These are the benefits. And coming to this, uh, it is also associated with preterm labor, decrease of venous return, and also there can also be fetal complications. Uh, then, um, yes.
Yeah. So who will you involve in the care of this patient?
So first, I will involve the critical care team along with the anesthetist, the consulting surgeon, the consulting obstetrician, along with the neonatologist for the baby.
And where will you manage this case post-operatively?
In the obstetric HTU.
Okay, so can you tell me about different reasons why the blood pressure is decreasing in this patient?
In this patient, since the patient is pregnant, the pregnant uterus can compress the aorta caval region, leading to decrease of venous return. Next, if the fluid resuscitation is not adequate, or if the patient is having any ongoing hemorrhage, that can also lead to a fall in the blood pressure. And mm, yeah, sir, I think.
Okay. So can you define what is preload?
Preload is the amount of blood that is in the present in the heart just before ejection.
Okay, so can you define what is shock?
A shock is a state of inadequate tissue perfusion, resulting in decreased delivery of blood into the tissues and the cells to meet the metabolic demands, thereby decreasing the amount of oxygen delivery.
Okay, so
Okay,
can
so
you
can you
define
define
what is
what is
shock?
shock?
So, shock is a state of inadequate tissue perfusion, leading to decreased tissue metabolic demands to meet the cellular metabolic demands, resulting in insufficient oxygen delivery.
Yeah. So what will be the body's response towards this decreased blood pressure?
Uh, the body has two types of response, the baroreceptor reflex and the hormonal response. Baroreceptor reflex is something that happens immediately, and the hormonal response happens later than the baroreceptor reflex. In the baroreceptor reflex, the carotid body and the aortic arch is stimulated, thereby increasing the sympathetic activity, leading to increased tachycardia and increased cardiac contractility, leading to increased stroke volume and to increase the blood pressure. And coming to the hormonal reflex, this also helps in activation of renin angiotensin aldosterone system. So the renin is produced in the kidney, the renal tubules, which activates the angiotensin 1 to angiotensin 2. And also it results in the activation of antidiuretic hormone ADH. Basically, there is salt and water retention leading to increase of blood pressure.
Okay, so can you tell me what are baroreceptors?
Carotid, sinus, and aortic arch.
Okay. So what are the factors which affects the venous return?
Uh, there are the factors that can increase the venous return are increased fluid resuscitation, increased BP, increased baroreceptor reflex, and the factors that decreases the venous return are aortocaval compression. And if the patient, like in this condition, if the in this case, if the patient is in reverse Trendelenburg position, that can also lead to decreased venous return. So the calf muscle pump helps in increasing the venous return. So if there is any failure in the calf muscle pump mechanism, or if there is any decreased venous compliance, that can result in decreased venous return.
Okay. So can you name some devices which are used for the mechanical DVT prophylaxis to improve the circulatory parameters in this patient?
So we can use intermittent pneumatic compression devices and also TEDS. TEDS is a graded compression stocking.
Okay, so what can you do to improve the preload in this patient?
We can give IV fluids to the patient. We can also give blood. We can also achieve early hemostasis if there is any hemorrhage. And we can reverse the reverse Trendelenburg position in this patient. We can also remove the aortocaval compression by either putting the patient in left lateral position or displacing the uterus towards the left. And we can also give foot and elevation. Um, if the blood pressure does not increase with IV fluids, we can also start with the inotropic and vasopressor agents.
Okay. So regarding the benefits, you said right that there will be the control of infection by undergoing this surgery, but the risks include that it can
Okay.
result into preterm labor, it can result into
Okay.
intrauterine fetal death, and it can result into DVT formation in the pregnant lady because of the hypercoagulable state.
Okay.
Okay. So
Okay,
regarding
sir.
why the blood pressure is decreasing, like there is a patient who is undergoing surgery. So it could be because of active bleed, it could be because of inadequate resuscitation, and it could be because of reverse Trendelenburg position. It could be because of sepsis resulting into septic shock-like picture. Like there are multiple
Okay.
factors, okay? And there could be intraoperative
Yes, sir.
hemorrhage as well. So while you
Mm,
answer
mm.
this part, you will keep these in mind, which you have answered in the last part, that what will you do to improve? So you will be countering for all these. So how will you improve the condition? You will resuscitate the patient with fluid, blood. If that fails, then you can move towards inotrope. In the meanwhile,
Inotropes.
you will make sure that there is adequate hemostasis. You will
Okay.
change the position of the patient. So, like these are the things which you can do. And similarly,
Okay, sir.
the compression of the IVC can be eased by left lateral position.
The compression of the IVC, sir.
Can be
Left.
can be
Okay,
released.
sir.
Yeah.
Okay. Okay, sir. Okay. Got
Now,
it.
when you are asked about the body's response to the decreased blood pressure, so you don't have to say like there are reflex mechanism and there is hormonal mechanism. You will say that there are two
Okay.
types of systems. One has an acute response and the second has a late response. The acute
Okay.
response is through the reflexive mechanism based on the baroreceptors. Then you will tell its detail. And the later response system is the hormonal response. In that, we have
Okay.
catecholamines and mineralocorticoids.
Okay, sir.
Mineralocorticoids function through the renin angiotensin aldosterone axis.
Okay.
And then you will wait that does the person on the other end asks any other detail about this or not. Okay.
Okay. Okay.
Okay. So rest of the answers were pretty much good.
Okay.
Okay.
Thank you, sir.
So next you have this scenario, review it, and then we will start.
Okay. Okay, sir.
Okay. So define what is hypothermia.
Hypothermia is a decrease in the body temperature less than 32 degrees Celsius. Uh,
Okay.
it's-
So how can you measure the core temperature of the patient?
the core temperature can be measured by uh, esophageal route. Rectal temperature can be measured. Uh, yes, sir. I think.
So what are the risk factors of developing hypothermia?
Uh, the risk factors are if there is a large volume of fluid instilled, which is unwarmed, and in cases of massive blood transfusion, if the patient is not properly warmed with blankets during surgery, and in patients who are extremes of age, in patients who are thin built, that is with low BMI, and if the patient is having any endocrine disorders, if the patient is in sepsis, in a long duration of surgeries, like in this case, and also in if the patient is given general anesthesia.
Okay, so what are the
Uh,
yes.
And during abdominal wash, if you're giving abdominal irrigation with cold fluids.
Okay.
Okay.
So what are the different ways of heat loss?
The heat loss can be with the evaporation from open wounds and respiratory losses, sweat losses, radiation, that is heat loss to the cooler surroundings, or if the patient comes in contact with cold surfaces, if there is any decreased temperature in the operating room, and the patient is not properly warmed.
Okay. So give me one potential intraoperative pathology that can arise as a result of hypothermia in this patient.
Disseminated intravascular coagulation.
Okay. So elaborate complications of hypothermia.
Complications can be first of all, the patient can go into coagulopathy, DIC. There can be a risk of increase in bleeding. There can be cardiac complications like arrhythmia and myocardial ischemia. And the patient can also go in for acidosis. Then since the patient is under general anesthesia, there could be delay in recovery from the anesthesia. The wound healing can also be delayed. There could be chances of wound infection, and the patient can also have shivering to increase the body temperature.
Okay. So what measures you can take to prevent these complications from happening?
First, we can always provide warming blankets to the patient, like Bahaga blankets, to prevent heat loss. Then we can give warmed IV fluids, or also irrigating fluids. Also, we can give warm irrigation fluids. Then the OT temperature can be optimized to decrease the heat loss. Then we should also continuously monitor the temperature of the patient. Since the NICE guidelines recommends maintaining temperature at more than or equal to 36 degrees Celsius throughout the perioperative period.
Okay, so can you name the types of blankets which can be used in the prevention of hypothermia?
The types of blankets used are space blankets, then forced air warming blankets like bear hugger blankets, then electric warming blankets.
Okay, so define what is DIC.
DIC is an acquired syndrome characterized by widespread activation and consumption of platelets and coagulation factors, leading to thrombosis in the small vessels and increased risk of bleeding tendency.
Okay, so what is the cause of DIC in this patient?
Hypothermia is the cause of DIC, along with the massive blood transfusion, then sepsis. Mm, the patient can also have due to massive hemorrhage. Uh, that's it.
Okay. So can you tell me about the treatment of DIC?
Uh, we can give blood component like platelets since there will be platelet deficiency, and also fibrinogen complex concentrate, cryoprecipitate, and fresh frozen plasma. We can correct the hypothermia, prevent hypothermia. We can correct sepsis, acidosis, and also maintain the blood perfusion.
Okay, so who will you
Yes.
involve in the care of this patient?
First of all, I will involve the consultant anesthetist, the intensive care team, and the consultant vascular surgeon, and also the laboratory, since the lab investigations are very important, and also hematologist.
Okay. So can you tell me what are the indications of platelet transfusion?
In cases of thrombocytopenia in DIC, where there is a decreased platelet count, then in cases of massive transfusion protocols (MTP), then if in older patients or in cases where there is low platelets, so before procedure we can infuse platelets.
And what is the shelf life of platelets?
5 to 7 days when stored in 20 to 24 degrees Celsius temperature with continuous agitation.
Okay. So what are the stages of hemostasis?
The stages of hemostasis are vasoconstriction, platelet adhesion, and platelet aggregation.
Okay. So how does vascular surgery interfere with each of these phases?
How does vascular surgery? Sir, I didn't understand the question.
Okay, like
Uh,
there are three stages of hemostasis. Okay.
yeah, yes, sir.
How does vascular surgery affect each of that stage?
Vascular surgery. Uh, the tissue injury can cause platelet activation in the blood vessels, leading to platelet adhesion and aggregation, and also vasoconstriction.
Okay. So Can you define what is massive blood transfusion?
Massive blood transfusion is the transfusion of more than one blood volume of the patient within 24 hours, or more than transfusing more than 10 units of blood in 24 hours, or 4 units of packed red blood cells in 1 hour in a patient with ongoing bleeding.
Okay, so what are the complications of massive blood transfusion?
DIC, then hypothermia. mm, Then there can be citrate toxicity, there can be hyperkalemia, hypocalcemia. Then the patient can go into acidosis. There can be transfusion-related acute lung injury.
Okay. So what are the measures which can be taken to reduce the blood loss intraoperatively?
We can achieve early hemostasis. We can prevent hypothermia. Then we can maintain normothermia in the patient, and optimized coagulation. Then we can also give IV tranexamic acid and any other blood components.
Okay, so what are the early post-operative complications of the aneurysmal repair of a ruptured abdominal aorta?
The patient can go into sudden hypotension. The patient can develop arrhythmias, then myocardial infarction. In the immediate post-operative period, regarding the respiratory complications, the patient can develop atelectasis, pneumonia, then respiratory failure. Coming to the renal system, patient can develop acute kidney injury. Then there can also be a loss of graft by graft thrombosis, or the patient can also develop limb ischemia following graft thrombosis. In the regarding the bowel, the patient can develop mesenteric ischemia. Then there can also be bleeding, DIC. There can be sepsis, wound infection. Yes.
Okay. So your answers were good, but you can improve them.
Thank
Okay.
you.
So
Thank
regarding
you, sir.
how to measure the core temperature, you can say that there are two types
Mhm.
of methods, the invasive and
Okay.
non-invasive.
Okay, sir.
Non-invasive is the usual method by which we measure, like using a thermometer. Invasive
Okay.
methods include esophageal, intravesical, tympanic membrane, and PICO. Okay.
Okay, sir.
And regarding the risk factors and etiological factors, they are more or like the same. Okay. So major
Okay.
surgery, more time to surgery, giving the patient non-warmed fluid, not
Okay.
warmed blood, giving
Okay.
massive blood transfusion to the patient. And with respect to anesthesia, the anesthetic gases can also potentiate the hypothermia. And one of the
Okay, sir.
peri-operative hypothermia is caused by pre-operative hypothermia. Okay, that
Okay.
prior to the surgery, the
If
patient
the
was
patient is having.
already having some decreased temperature, so that will be potentiated by the surgery.
Okay, sir.
Okay, regarding the complications, it's better to divide them according to the systems. Okay,
Systems. Okay, sir.
so you can say that in cardiovascular system, there will be a decrease in the cardiac output. In the respiratory, there will be VQ mismatch. Like you can remember one from each of the systems. So it will be very easy for you to recall. In
Okay.
the renal, it will be decreased renal blood flow and hence decreased urine output. Hematological manifestation will be DIC. In the
Okay.
GIT, there will be decreased gut motility. And in the neurological, there will be reduced cerebral blood flow. So the idea is that everything will be reduced. Cardiac
Okay.
output, cerebral blood flow, renal blood flow, and gut motility. Okay.
Okay, sir.
Danish, sorry, I'm interrupting you.
Yes.
Regarding this question, complication of the hypothermia, this was a question he was asking me specifically about these complications. Like he wanted to ask me about every system, at least four to five systems, and he was trying to shed a light on every aspect of the hypothermia on different systems. Like.
Okay. Thank you for your input, Dr. Daud. Okay.
Okay.
So regarding the prevention, again, you can classify your answer. Like there could be pre-operative measures, there could be intraoperative measures, and there could be post-operative measures. So the pre-operative is that avoid the surgery if already the patient is having core temperature less than 36.
Okay.
Intraoperatively, the theater temperature should be 21. Avoid doing a prolonged surgery. Give the patient warm IV fluids, humidified anesthetic gases, and patient should be exposed as minimum as possible. So
Okay,
I
sir.
guess you're understanding the etiological factors which you have explained, you have to give one preventive measure against each. So when you link the
Okay, sir.
questions, it will be very easy for you to memorize them.
Okay.
Similarly, post-operatively, you will keep the patient in the recovery room until the patient has a temperature of more than 36. And during the transfer, you will make sure that the patient has a bear hugger system to prevent further hypothermia.
Okay, sir.
Okay, so regarding the DIC, you explained very well.
Okay,
I've
sir.
explained the stages and its correlationship. Let's talk about that. Okay, so you told me that there are three stages of hemostasis. First is the
Yes.
contraction of the blood vessel,
Yes.
then is the
Yes.
formation of the platelet plug and the fibrin
Platelets.
clot being potentiated by the
Aggregate.
coagulation cascade. Okay,
Yes.
so with respect to vascular surgery, when there is removal of the vessel by the vascular surgeon, it will result into contraction, that is stage one.
Okay.
Now, the formation of the platelet plug will be impaired because of decreased platelets, which we have previously discussed in this patient. Like this, he or she was having decrease in the platelets.
Okay.
Then the fibrin formation will also be affected because of the massive transfusion, resulting into dilution of the clotting factors.
Okay.
Okay, so that is how you relate the current situation of the patient with the stages of hemostasis.
Okay, sir.
And regarding the complications of massive blood transfusion, so I guess you said almost all the things, but it will be better if you say like there are two types of transfusion problems. One is immunological, one is non-immunological. Immunological, you
Okay.
can add acute hemolytic reaction, febrile non-hemolytic reaction, acute kidney injury, acute lung injury. In the non-immunological, you can say that there will be decrease in the calcium, increase in potassium, increase in fluid, increase in iron overload, hypothermia, and coagulopathy.
Yes.
Okay, so like you quantify your answer or classify your answer, it will be very easy to reproduce on the exam day because there will be a lot of stress on the exam day. So try to memorize them prior.
Okay, sir.
Okay. So
Okay, sir.
next we have the this scenario. Kindly review it and then we will continue.
Okay, sir. Mm, Okay.
Okay, so what is the pathophysiology of aortic stenosis?
In aortic stenosis, there is lipid accumulation and fibrosis followed by aortic stenosis.
Okay, so how can you
Yes.
calculate the coronary perfusion pressure?
The systemic diastolic artery pressure minus the left ventricular end diastolic pressure.
Okay, so what is the clinical picture of aortic stenosis patient?
There is mainly the clinical triad of symptoms, syncope, angina, and dyspnea. Apart from that, there can also be paroxysmal nocturnal dyspnea and orthopnea. Then, uh, yeah, that's it.
Okay, so can you explain the presence of syncope in aortic stenosis patient?
In the aortic stenosis patient, there will be following an exercise, there can be a vasodilatation. So mm, it needs an increased afterload to compensate in cases of vasodilatation because there can be decreased blood pressure. But in aortic stenosis, the afterload is decreased. So the blood pressure is decreased, leading to decreased blood entering the brain and syncope.
Okay. So comment on the ECG.
Um, so the CCG has irregular rhythm, and there is a left axis deviation and also a few ectopics, and there is a left ventricular strain as seen in the lead 1A2, V5 and V6. There is downsloping of the ST. So there is a left ventricular hypertrophy along with the left ventricular strain that happens in hypertensive patients.
Okay. So how can we calculate the heart rate based on the ECG?
In cases of regular rhythm, it is calculated by dividing 300 divided by number of boxes between two RR intervals. If the rate is irregular, then we can count the number of QRS in 30 large boxes and multiply it with 10.
Okay, so what complications of aortic stenosis can happen in this patient?
The patient can go into hypothermia. The patient can go into myocardial infarction and rupture of aortic dissection. And there can be sudden cardiac death, ventricular fibrillation, ventricular tachycardia. Yes.
Okay. So what investigations you will arrange for this patient?
We can do chest X-ray, 2D echocardiogram, and transesophageal echocardiogram.
Okay. So as this patient was booked for TURBT and you have identified this aortic stenosis in the pre-operative assessment. So what will you
Yes.
do regarding the surgery?
We have to assess the severity of the aortic stenosis. First, I will involve the cardiology team, the consultant surgeon, and the consultant anesthetist to check whether if the patient is fit to undergo the procedure. So if the patient is having a severe aortic stenosis, the surgery can be postponed, and prior the sur- we can first repair the aortic stenosis by valve replacement or valvuloplasty and TURBT 6 months following the aortic valve surgery.
So if the patient has a bladder cancer, will you proceed for the bladder surgery or the valve replacement surgery?
Mm, uh, If the surgery is delayed in a patient with bladder cancer, there can be spread of the cancer. But if the patient is taken up for bladder cancer surgery, the patient can go into the afterload compensation will not occur, and the patient can go into MI, sudden cardiac death, and MI and sudden cardiac death. So we have to prevent that. So we have to first correct the valve by doing a if you want to do an emergency surgery, then we can first correct the valve with a balloon valvuloplasty and then proceed with surgery 12 to 24 hours later, proceed with the bladder surgery.
Okay. So if in this patient you opt for valvular surgery, how much time you will wait before going for the cancer surgery?
In this patient, since it is a case of elective TURBT, we can wait for 6 months after the major aortic surgery to do the TURBT.
Okay, so will you give any antibiotic to this patient?
So no, sir, we don't give any antibiotics to this patient. According to the NICE guidelines and according to the SINE guidelines, we don't give any antibiotics to this patient.
Okay. So this patient was pretty much uh, very well done by you. So
Thank you, sir.
just a few things, okay?
Yes.
So why the patient develops syncope? It is just like a easy concept to understand, then you can produce it in your own words, okay?
Okay, sir.
So the patient is having a fixed cardiac output. When the
Okay.
patient undergoes any exertions through exercise or any other means, the body will have vasodilatation. There will be pooling of the blood, and there will be less amount of blood that will enter. And as a consequence, the less blood will reach the brain. And as a consequence of lack of oxygen, the patient will develop syncope.
Okay.
You like
Yes.
try to understand the basic pathophysiology. So you will not have to cram it. That will be like very easy for you in that case.
Okay, sir.
Okay.
Okay, sir.
Now regarding the signs, you can also tell that there will be narrow pulse pressure. There will be alternating strong and
Okay.
weak beats. There will be ejection
Okay.
systolic murmur.
Mama and split of S2.
Yes,
Paradoxical splitting of S2.
yes, these are very important signs. Okay.
Okay, sir. Okay.
Okay, so this is all about today's session. So we will continue uh, tomorrow or day after that. Okay.
Okay, sir. Thank you.
Welcome.